Hey everyone, and welcome. I'm absolutely thrilled to have you here today. As a healthcare professional, I constantly find that human anatomy, and especially the miracle of birth, is just as complex as it is fascinating. Today, we're going to explore the precise anatomical variables of a baby's position right before birth. By the end of this explainer, you'll have a really deep, intuitive understanding of exactly what healthcare providers are looking for as delivery approaches. Welcome to MediByte, where we make complex medical topics clear, accessible, and easy to understand for everyone. Think of this explainer as a comforting, highly visual consultation. So whether you're a student, a working professional, or just a deeply curious, focused learner, you are absolutely in the right place. Okay, let's dive into our roadmap for today. We'll be covering 1. Welcome to fetal positioning. 2. The ideal delivery position. 3. Common fetal position variations. 4. Understanding breech presentation. 5. Risks of intraamniotic infection. And finally, 6. Treatments and our MediByte wrap-up. Let's get right to it. Section 1. Welcome to fetal positioning. First up, we have presentation. Simply put, this refers to the part of the fetus's body that leads the way out through the birth canal. It's the presenting part. Now, usually, and most favorably, the head leads the way, but sometimes other parts, like the buttocks, a shoulder, or even the face can come first, which, as you can imagine, completely alters the mechanics of delivery. Next, we've got position. This specific term refers to whether the fetus is facing backward or forward in relation to the mother. Doctors look closely at the occiput. That's the bone right at the back of the baby's head. So if the baby is facing backward toward the mother's spine, that's called occiput anterior. But if the baby is facing forward toward the mother's pubic bone, it's called occiput posterior. Finally, let's define lie. This one refers to the overall angle of the fetus in relation to the mother and the uterus. An up and down angle, where the baby's spine is perfectly parallel to the mother's spine, is called a longitudinal lie, and this is completely normal. Sometimes, though, the baby lies horizontally, which is known as a transverse lie, or even at a diagonal angle, known as an oblique lie. Section 2. The ideal delivery position. Now, let's talk about the path of least resistance. For a normal vaginal delivery to be as smooth as possible, healthcare teams look for this specific combination: head first, facing backward, spine parallel to the mother, neck bent forward with that chin nicely tucked, and arms neatly folded right across the chest. This creates a perfectly aerodynamic shape, making vaginal delivery the absolute easiest and safest for both mother and baby. Section 3. Common fetal position variations. Of course, it's incredibly common for variations to pop up. A lot of times, it's just a matter of mechanics. Maybe the fetus is a bit too large for the pelvis, maybe the uterus has an unusual shape or some fibroids, or perhaps there are twins competing for space in there. It's really interesting to compare our ideal occiput anterior with the occiput posterior, which is affectionately, or maybe not so affectionately, known as sunny side up. When a baby faces forward, their neck is often straightened out rather than comfortably bent. So why does this matter? Well, a straightened neck requires significantly more room for the head to pass through the birth canal. And because of that extra space requirement, doctors sometimes need to step in with a vacuum device, forceps, or even opt for a cesarean delivery. There are also a few rarer presentations we need to be aware of. In a face presentation, the baby's neck arches back entirely so the actual face leads the way. In a brow presentation, it's moderately arched. And in a transverse lie, the baby is entirely horizontal, presenting a shoulder. Now, the reassuring news here is that modern medicine handles these brilliantly. Babies in a face or brow presentation often just correct themselves to a standard head-first position during labor. But if they don't, or if we're dealing with a transverse lie, a cesarean delivery is a safe, standard procedure to ensure a healthy arrival. Section 4. Understanding breech presentation. So, a breech presentation is a variation where the baby's buttocks, or sometimes even the feet, are positioned to deliver first, right before the head. We see this frequently in instances of premature labor, multiple gestations like twins, or abnormal uterine shapes. Delivering a breech baby vaginally actually poses some pretty significant risks. The crucial point here is understanding the exact physical mechanics of why it's risky. A baby's hips and buttocks simply aren't as wide as their head. Therefore, if the hips pass through the cervix first, they don't stretch the passageway quite enough for that wider head that has to follow. The head can literally get trapped. When this happens, it puts immense pressure on the umbilical cord caught in the birth canal, severely restricting oxygen. And naturally, this lack of oxygen drastically increases the risk of brain damage or even death.
Because of this mechanical bottleneck, a C-section is usually the preferred route for breech babies. But here is where medical science is just amazing. Doctors can proactively solve this problem before labor even begins through a procedure called an external cephalic version. Around 37 or 38 weeks, a doctor can administer a medication to relax the uterus and prevent contractions. Then they literally use their hands to press on the outside of the mother's abdomen and carefully turn the baby into that optimal head-first position. It is hands-on medicine at its absolute finest.
Section 5. Risks of intraamniotic infection.
Let's move on and see how this all builds together. When a fetus is in a difficult position, like that occiput posterior we talked about earlier, it often leads to a prolonged labor. Now, prolonged labor, or an early rupture of the membranes, what we commonly call your water breaking, removes the physical barrier protecting the baby. If there's a long delay between that rupture and the actual delivery, normal vaginal bacteria have the opportunity to travel up into the uterus, infecting the amniotic fluid, the placenta, and the membranes.
This is a very serious condition that requires immediate medical attention, as the complications can be severe. For the fetus, this infection can lead to sepsis, pneumonia, meningitis, seizures, and even cerebral palsy. And for the mother, the risks include bloodstream infections, postpartum hemorrhage, and dangerous blood clots. In severe, untreated cases, it can escalate to placental abruption or septic shock. This is precisely why, once the membranes rupture, timely delivery becomes an absolutely critical priority for the healthcare team.
To diagnose this kind of infection, doctors are constantly on high alert for clinical signs, like maternal fever paired with an unusually rapid heart rate in either the mother or the fetus. They're also looking for abdominal pain or a foul-smelling discharge. To confirm it, they'll draw a complete blood count to check for elevated white blood cells, or if the symptoms are a bit unclear, they might perform an amniocentesis to directly analyze the amniotic fluid for bacteria.
Section 6. Treatments and MediByte wrap-up.
While the complications we just discussed are definitely serious, healthcare professionals are incredibly adept at successfully managing and preventing these infections today. If an intraamniotic infection is diagnosed, the immediate action is to administer intravenous antibiotics and medications like acetaminophen to lower the fever. Then, the goal is to promptly schedule delivery, often by inducing labor. And it's really important to note here, a C-section is not strictly mandatory. As long as the mother and fetus remain stable and the active antibiotics are flowing, doctors can often safely guide a vaginal delivery.
Prevention, of course, is a massive part of modern prenatal care. If a patient's water breaks early, doctors will strictly limit pelvic exams to avoid pushing any bacteria upward. Furthermore, standard care now dictates screening all pregnant patients for Group B streptococcus around 35 to 37 weeks. If the screen is positive, it's no cause for panic. The patient is simply given antibiotics during labor to proactively protect the baby.
As we wrap up this explainer, I want to leave you with a quick thought. Considering the incredible complexities of human anatomy, from the exact angle of a baby's chin to the microscopic defense against bacteria, how does modern medical science continue to adapt and make childbirth safer every single day? It truly leaves you in awe of both medical innovation and the sheer resilience of the human body.
Thank you so much for joining me today. I hope this structure dive helped clarify these essential medical concepts for all you focused learners out there. If you enjoyed this explainer, please hit that like button, share it with your peers or study groups, and absolutely subscribe to the MediByte channel for more deep, highly visual dives into healthcare and medicine. Stay curious, and I'll see you next time on MediByte.